Welcome back, medical coders, billing specialists, and auditors to the Explainer series. I am absolutely thrilled to have you here for part 12 of our shoulder arthroscopy and CPT coding mastery masterclass. If you've been following along with us, you know we're on a pretty massive mission here to completely demystify complex surgical coding. We're doing that by breaking down the raw anatomy, the actual surgical techniques, and of course, the incredibly strict guidelines that govern our claims. Today, we're tackling one of the most highly scrutinized procedures in all of orthopedic coding. So grab your notes, get ready to lock in, because this is going to be incredibly valuable. But hey, before we break new ground, let's do a lightning-fast 30-second recap of our previous lesson. In Part 11, we completely cracked the code on subacromial decompression and those really strict rules surrounding the add-on code 29826. Remember, that code absolutely requires clear, undeniable documentation of bony work performed on the acromion. I mean, a true acromioplasty, not just clearing out some soft tissue. We also saw exactly how the NCCI bundling edits shift when you report 29826 alongside other specific codes. If you've got that logic locked in your memory, you are perfectly primed for today's advanced topic. Okay, let's dive into this. Here is our high-stakes mission for today. We'll start with an anatomy briefing, then move into mastering CPT 29827, the open conversion rule, modifier mastery, case files, and we'll wrap it all up with key takeaways. Let's get to work. Section 1, Anatomy Briefing. Every good surgical coder needs to understand the crime scene we're investigating, right? To code the rotator cuff accurately, you have to literally be able to visualize the structures the surgeon is manipulating in the OR. So the shoulder joint, the glenohumeral joint, is a classic ball and socket joint. But its stability heavily relies on 4 specific muscles that originate way back on the scapula and wrap all the way around the head of the humerus. You can easily remember them using the acronym SITS, the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. These 4 muscles, they work together as one single functional unit, just to let you lift and rotate your arm. Now, when a patient suffers a bad sports injury, or maybe experiences years of repetitive overhead motion, these tendons can actually tear right away from the bone. Reattaching them is the precise surgical target we are focusing on today. Section 2, Mastering CPT 92927. Now, what's really interesting about this next step is how we translate that anatomy into our core base code. When a surgeon goes in to repair those torn sits tendons, the official CPT descriptor for 29827 is arthroscopy shoulder surgical with rotator cuff repair. Whenever an arthroscope is inserted along with additional instruments to fix that torn tissue, this is your go-to code. But listen up, because here is an incredibly important caveat that auditors are constantly hunting for. Localized debridement of the rotator cuff tissue is completely bundled into this code, period. It's considered an integral part of preparing the tendon for repair. So please do not attempt to report a separate debridement code just because the surgeon cleaned up the frayed edges of the rotator cuff they were about to sew back together. Let's actually walk through the surgical technique for a second, because reading an operative report should feel kind of like watching a movie play out in your mind. The procedure generally follows 4 really distinct steps. First, the surgeon visualizes the tear with the arthroscope. Second, they perform what's called footprint decortication. That just means they scrape the bone at the greater tuberosity to create a bleeding bed, which is what actually promotes the healing. Third, they drill and insert suture anchors directly into that bone. I want you to literally visualize a sleek titanium or biocomposite anchor locking firmly right into the tuberosity. Finally, they pass the sutures through the torn cuff tendons using mattress or simple configurations, tying some incredibly complex knots to tension that tendon right back down to the bone. And this brings us to one of the most absolutely critical rules in all of orthopedic coding. We call it the rule of 1. For CPT 29827, there is a strict maximum of 1 unit allowed per shoulder per session. It absolutely does not matter if the surgeon repairs just the supraspinatus, or if they repair the supraspinatus and the subscapularis, or even if they spend 3 grueling hours repairing a massive tear involving all 4 sits tendons. The entire rotator cuff is treated as a single anatomic structure for coding purposes. You report strictly 1 unit of 29827 per shoulder. Never, ever try to bill multiple units based on the number of tendons repaired or the number of suture anchors they used. Section 3, the open conversion rule. Okay, so we have our foundation built. But what happens when an arthroscopic procedure suddenly gets complicated? Maybe visibility is lost, or the tear is simply too massive, demanding that the surgeon completely abandon the scope and make a larger open incision. Well, this brings us to a major plot twist that I want you to burn into your memory: the golden conversion rule. If a procedure begins arthroscopically but requires immediate conversion to an open or mini-open surgical approach, you report only the appropriate open procedure code. You must never, ever bill both the open repair code and the arthroscopic repair code together for the same shoulder during the same operative session. In the eyes of coding, that arthroscopic portion effectively just becomes a diagnostic or preparatory step for the definitive open procedure. So you might be wondering, if we're converting to an open code, which open code do we actually use? It's simple. We select the correct code based purely on the injury's etiology, mapping it directly to your ICD-10 diagnosis. If the surgeon converts to an open procedure and the tear was caused by a sudden, acute injury, a traumatic etiology mapped to an S-series ICD-10 code, you're going to report CPT 23410. Conversely, if the conversion happens and the tear is the result of long-term wear and tear, meaning a chronic or non-traumatic etiology mapping to an M-series ICD-10 code, you report CPT 23412. It's actually a beautifully logical system if you just trace the diagnosis straight through to the surgical intent. Section 4. Modifier Mastery. Now that we totally understand conversions, we need to lay down the laws of the land regarding modifiers. Because think about it. If a surgeon spent a whole hour painstakingly working through the scope before finally having to convert to an open procedure, they deserve to be compensated for that intense effort, right? This is exactly where Modifier 22 becomes your absolute best friend. Modifier 22 stands for Increased Procedural Services. You append Modifier 22 to the open procedure code, so either 23410 or 23412, to explicitly account for that substantial diagnostic and arthroscopic work that was performed right prior to the open conversion. Now, of course, this absolutely requires robust, undeniable documentation in the operative report detailing exactly how much extra time, extra effort, and specific work was done arthroscopically before the decision to open the shoulder was finally made. So use Modifier 22 on the open code to capture the prior arthroscopic work. Makes sense. However, you might be tempted to use Modifier 59, the distinct procedural service modifier, to try and unbundle the arthroscopic code 29827 from the open code. Well, the crucial point here is this. Modifier 59 is strictly 100% prohibited here. You absolutely cannot use Modifier 59 to report both the open and arthroscopic repair codes together. Why? Because all of that work was performed in the exact same anatomical site, the shoulder, during the exact same session. Modifier 22 is your valid legal tool. Modifier 59 will just trigger an immediate audit flag. No way around it. Section 5. Case Files and Scenarios. All right, it is time to put your detective hats on. Let's apply these complex coding laws to a real-world operative report scenario. I want you to see if you can translate the clinical narrative into the correct code before I reveal the answer. Ready? Here is case file number 1. The surgeon's notes state, performed a meticulous arthroscopic repair of both the supraspinatus and subscapularis tendons in the right shoulder. A total of 4 biocomposite suture anchors were utilized for fixation. Think about the anatomy. Think about the rules we literally just discussed. How should this be reported? Got a guess? Okay, the correct strategy is to report CPT 29827 with the RT modifier for the right side and absolutely, positively only 1 unit. If you said 2 units because 2 tendons were repaired, or maybe 4 units because 4 anchors were used, remember the rule of 1. All 4 sits tendons represent a single anatomical functional unit for coding. Whether it's 1 tendon or the whole shebang, it is always a single unit of 29827. Let's step it up a notch with case file number 2. The operative report reads, the procedure began arthroscopically, encountered severe retracted tearing and adhesions. After 45 minutes of extensive arthroscopic mobilization and debridement, visibility remained extremely poor. Converted to a mini open repair for this chronic, non-traumatic tear of the right shoulder. So what is your specific coding strategy here? Think about the timeline of events. Excellent work if you caught all the clues there. The correct reporting is 23412-22TR. Now, why is that? First off, we have an open conversion, meaning the arthroscopic code 29827 is completely dropped, gone. Second, the tear is chronic and non-traumatic, which points us directly to the open code 23412, not 23410. And third, the surgeon spent 45 minutes doing extensive, documented arthroscopic work prior to the conversion, which perfectly justifies appending Modifier 22 to capture that increased procedural service. Boom, perfectly coded. Section 6. Key Takeaways. And this brilliantly illustrates how every single word in an operative report maps to a specific coding guideline. To make sure this all sticks, let's rapidly summarize the absolute critical success factors from today's explainer. Here are your golden rules. Number 1, a strict maximum of 1 unit per shoulder for arthroscopic rotator cuff repair, CPT 29827. Number 2, if a procedure converts, you build the open code only. Never ever build the arthroscope and open repair together. Number 3, when you do convert to an open code, match the code to the exact etiology. Traumatic gets 23410, chronic gets 23412. And finally, number 4, use Modifier 22 on the open code to get credit for the scope work, but absolutely never use Modifier 59 to try and bypass the bundling edits for the same anatomical site. You guys are doing fantastic with this material. Mastering the rotator cuff and open conversions is a massive milestone in orthopedic coding. But hey, we aren't done with the shoulder just yet. Coming up in part 13, we are going to untangle the complexities of the biceps tendon, specifically looking at the heated debate of biceps tenotomy versus tenodesis, navigating CPT 29828 and 23430, and we'll even dive into the unlisted code realm for superior capsular reconstruction. You definitely will not want to miss it. So keep studying those operative reports and keep rigorously applying these logical frameworks. Ask yourself a quick question. In your last batch of orthopedic claims, how many times did you see a conversion improperly unbundled with a Modifier 59? Honestly, it happens way more often than you'd think. Keep your eyes peeled out there, and until next time, decode healthcare with Harshal.